This is a simulation update for the Northwest Deanery School of Medicine for the meeting on September 2010. My name is Dr. Ashish Vyas. Over the coming slides, I'm going to talk about how the foundations of simulation training are starting to develop. I'm going to focus particularly on CT2 training, but we'll look at where we are up to with practical skills training for year 1 and an exciting new foundation simulation program. I'm going to talk about the challenges we've encountered trying to get new sites involved and development of faculty and development of new material. Also, I feel very strongly that we need to look at supporting delivery from individuals and new sites and how we're going to achieve this. And finally, I think we're at an appropriate time to look at how we're going to validate the training that we're going to deliver, and also whether there is a role for simulation and research to sit side by side to ensure that the delivery of training that we're going to undertake is fit for purpose. The current state of play with regards to training days is that the CT1 Practical Skills Day is good to go. The CT2 dates and sites have been confirmed, but as I will discuss, the training material is in development. There is a simulated medical assessment, resuscitation and treatment, or SMART course, which has been developed for foundation year doctors, and this has been finished and the dates have been confirmed. If we focus now on the CT program, the practical skills training days for 2010 will be based at Preston Hospital, with shadowing of tutors from University Hospital South Manchester and, with any luck, from doctors from Hope Hospitals as well. The vision is that in 2011 there will be 3 sites undertaking practical skills training days, and in 2012 I hope there will be multiple sites where locality-based practical skills training and will occur, with tutors being able to access material and hopefully mannequins if required. The CT2 training days for this group of trainees will occur at Preston and University Hospital South Manchester. The structure of CT1 training days is not going to change this year. There will be 4 skill stations: lumbar puncture, chest drain placement, ultrasound guided central line insertion, external pacing with airway management. Trainees will have individualized supervision undertaking the procedure on simulated mannequins. But as importantly, there will be interactive group discussions about appropriateness of the procedure, the timing of the procedure, anatomy for safe placement of a chest drain, for example, as well as aftercare once the procedure has been undertaken. There will also be an assessment of generic competencies such as non-touch technique. The CT2 program will, over a day, look at 4 stations of 90 minutes each. Station 1 will use high fidelity simulation looking at medical emergencies, but the focus will be on teamwork, leadership and communication skills. In years to come, sites which do not have high fidelity simulation will be able to use simulated patients to perform and undertake Station 1. Station 2 is a virtual ward round station, almost akin to an OSCE. There will be a focus on clinical assessment, diagnosis, development management plans and prescribing. There will be a simulated patient for each station and a trainer for each station. There will be the potential of interactive group discussions after the 4 stations and clinical scenarios have been undertaken by the trainees. Station 3 is a communication skills station using simulated patients and trainers. It not only looks at the interaction we have with our patients and their relatives, but also within team members, such as handovers from between shifts in medical assessment units, the potential handover of a patient from one specialty to another specialty safely, and also discussions with peers where one individual feels, or a group of individuals feels, that one peer is failing his duty of care, for example. Station 4 is more akin to the PACES. It is a history-taking station looking to draw out salient points centered around diagnosis, management and prescribing, but will not only look at elective history-taking, but also history-taking within an acute environment. The CT2 days, all trainees will have individualized potential to have feedback, supervision and undertaking skills, The feedback will occur not only from the tutors but simulated patients and peers. There will be interactive group discussions. There will be a focus on teamwork, leadership under pressure in particular, verbal and non-verbal communications. We hope that the trainees go away from CT2 training day to be able to undertake a personal reflection of what they have been fed back and produce a reflective piece for their PDP. The SMART course is supporting transition from Year 5 students into foundation trainees. It is a mixture of lectures, simulation, feedback and interactive discussions. It is focusing on core common medical emergencies. It supports development of assessment, diagnostic skills. It looks predominantly, however, on communication skills, teamwork, leadership, and also the foundation year trainees understanding their limitations and when to call for help. One of the most difficult things over the last few months has been trying to engage faculty and new sites. We have succeeded in that University Hospital South Manchester is now going to be the second site where simulation training will occur within our region. We are waiting to meet with Hope and do a venue assessment as well. We feel strongly that simulation to occur effectively, we will need to support these new sites and also current sites, and therefore the new deanery simulation account which has been set up will hopefully support the payments for simulated patients, development of material, IT support, and acquiring new equipment as required. More importantly, it is important that both the CT trainees and the ST trainees are involved in delivery of their own training. And so we hope as years go on that we will get trainees to develop material and senior trainees to train up more junior STs and CTs, for example, as time goes on. And this process is currently starting to develop with regards to development and writing of new material. We've also looked at each site having a lead for simulation. So for University Hospital South Manchester, Dr. Ray George is going to be the simulation lead. As well as this, we've looked at specific skills that need leads. So for communication skill, for example, we've asked Dr. Nikki Barr, who has a significant communication role within the undergraduate department, to lead the delivery of simulation and communication for the faculty. We hope over the next few years that we will be able to validate the training that we undertake, not only with regards to looking at a consensus opinion from feedback over a few years to change courses, but also the ability to assess material before it's put into a course, and also try to keep the material fresh and updated as time goes on. And these processes are already occurring for CT1 and the new material that we're writing for CT2. We've also engaged with medical school in the form of Dr. Cameron Khan, their simulation lead, as well as a well-known simulation research unit in Utrecht under the auspices of Dr. Pam Cater, to look at engaging in assessment of the training that we're delivering, and to see whether there are things that we can learn from the processes that we're embarking on. I'm very grateful for your time to listen to where we're up to. I'm sure at the School of Medicine's meeting I'll be able to answer any questions. Thank you for your time, and this ends my presentation.